Before I introduce our speakers for this morning, I just wanted to put a little pitch in for our upcoming pediatric refresher course. As those of you know who've been around for a while, we've been holding this refresher course for many years. This is our 45th annual pediatric refresher conference. And like everyone else around the world, we've had to make a shift to a virtual platform for our course this year. So whereas in previous years we had a 2-day course, this year it will be a 1-day course. And I think the committee has put together a really fantastic course with focus on pediatric respirology and allergy, as well as a number of surgery subspecialty issues. I think the day will be great with a number of presentations on common issues, updates, and new developments. And I think it's really great that we have a number of the subspecialties focused in this day. So the date is Saturday, November 14th, and I think it will be a really fantastic day. We hope you'll join us. If you have any difficulty with registering, please contact Mariana. She's the co-host for our rounds today and our CME coordinator. So really, really great program, and I hope to see you at that program on November 14th. So with that, we'll shift over to our presenters for this morning. I'm very pleased to introduce an enthusiastic selection from the PGY3 group. Our presenters this morning are Dr. Heather Dunlap, Dr. Zoe Lazaris-Brunner, Dr. Vivian Ng, and Dr. Stephanie Zahradnik. And I have to say, Zoe is not here today because she's busy with interviews, but apparently she was the inspiration behind this. I think her co-host will give her due credit. When we introduce when we have speakers, we ask them for a bio. I'm just going to read to you what this group said because I thought it was quite fun. So Heather, Zoe, Vivian, and Stephanie are PGY3 pediatric residents at CHEO. They love working with children each day. I believe that's very true. And learning pediatrics through various styles and methods in their training. They've acquired a great deal of fruitful learning from podcasts that they used to bring to weekly trivia. They look forward to the eventual return of trivia when they can continue to strive to not place last each week. So with that, the title of their presentation today is 4 P's in a Podcast, the Value of Podcasts in Medical Education. And with that, I'm going to turn it over to, I believe, Vivian is our first speaker. So welcome, Vivian.
So I'm actually going to take it away at the beginning. I'm Steph. We thought we'd introduce ourselves and start with telling you what our favorite podcasts are, and then we will take it away. So I'm Stephanie. We're all PGY3s. After you heard that lovely introduction, you know that. My favorite podcast is Radio Lab. And Zoe, as you heard, can't be with us. Her favorite podcast is Serial, which you'll hear about shortly.
And hi, I'm Vivian, and my favorite podcast right now is called Canadian True Crime, and then my second, I guess, would be Planet Money.
And I'm Heather, and I spent a lot of time last night thinking about this, and I think my favorite is Revisionist History with Malcolm Gladwell.
So I'm post call this morning. So Vivian is driving the slides. Everyone should be grateful for that. Our objectives I'll go over before Vivian takes away our chat. So first, we're hoping to review various learning styles in medical education. We then will discuss the growing popularity of podcasts kind of over time in popular culture as well as in medical education. Then we'll review evidence for the learning value that podcasts have in medicine. And then we will review some alternative learning methods that are approved by the Royal College for maintenance of certification.
Okay, so I'll get us started talking about podcasts themselves. So the first thing we'll start with is talking about what it is. At its core, it is very simply just an audio file you can download from the internet. It's originally a portmanteau of the words iPod and broadcast put together to make podcast. And there are so many different types of podcasts out there that can exist. So anywhere from ones where you have recurring hosts that talk about current news or topics each week, or completely improvised content that's just put out. It is completely free, it's completely on demand, as you likely know, and it is something that the four of us really enjoy as a medium. And now that you know the four of us enjoy it, we wondered about you. So we have two questions for you today, just to get to know our audience a little bit better about your use of podcasts. So if you haven't used PolEv before, if you go to the top link here, just polev.com/whatever that username is right now, you can answer the question. It's completely anonymous. It shouldn't ask for your name, and it will in real time show us your responses. So if you're sitting at a computer and not driving, get on the poll. First answer. I'll just give it like another 30 seconds or so. And stay on, because there's a second question. Ooh, fun. Okay. Okay, so I'll leave this on, but that's really interesting. And we were kind of expecting a variation in in different respondents, and it'll be interesting to be able to talk about this for people who've never really listened to podcasts, just as a medium to get into it for fun or for medical education purposes. So I'm going to flip us over to the second question. So for those of you that do listen to podcasts especially, do you listen to it for medical education purposes, or is it exclusively for fun? And yes, please put podcast recommendations in the chat. That is very welcome as well. Okay, I will leave it at that. Thanks for responding to the poll. I think it'll be really interesting for us to go through the rest of the presentation with some of this idea in mind, that we have an audience where some people never listen to podcasts, some do sometimes, and then some do all the time. And definitely we are some of the people that really listen to it a lot.
Great. So we decided to do a bit of a deep dive into the history of podcasting, since none of us really were familiar with it. So here is the first article that coined the term podcasting. It was released by The Guardian in 2004, and it was really at the very beginning when the world was learning about this new media where it could either be radio clips from the radio that were downloaded onto your iPod, or it could be amateur radio. So the first term was in 2004. The next slide has a timeline. So the very first few years of how podcasts were developed. So really it was 2004 that, because iPods now existed, these smart guys, Dave Weiner and Adam Curry, developed a program. It probably would have been called an app now, that was called iPodder, and it allowed you to download MP3 files from radio clips or audio clips onto your iPod. So iTunes was smart, and Apple was smart. So in 2005, they actually made it much more convenient and developed their own programming that allow users to do this automatically. So they didn't need a separate way of doing it, which essentially made iPodder obsolete, but was a smart move on iTunes' part. And 2005 is really where things kind of exploded. So the big radio shows started to realize it was an up and coming thing. So Public Radio International created the first daily news podcast. There was actually the first president address was released as a podcast, which was George W. Bush. And then it was also the word of the year in the New Oxford American Dictionary. So it's actually been 15 years since podcasts really had a presence in the world. But then things, I don't think a lot of us were actively listening to podcasts 15 years ago. I know that I wasn't. So what happened since then? Steve Jobs, in one of his interactive presentations, actually showed how you could create your own podcast through an app called GarageBand. So I don't know if anyone here creates their own podcast through that, but if you do, you can add that to the chat too. And then so that allowed a lot of people who were not involved in radio to suddenly start creating their own audio files. And then by 2013, there was 1 billion subscribers to Apple Podcasts. So that's not individual users, but that because, you know, a user can have multiple subscriptions, but still a huge, huge number. And 2014 is when this podcast serial came out, which some of you may remember. And it really captured, I think, a younger audience and true crime fans. And so since then, really tons of podcasts have been released, a lot on true crime and a lot on other things. And we'll focus on the medical ones for today. But by 2019, there was over 165 million users. That's almost, or more than half of the population of the States. So it's become a really, really, you know, broadly used media. So how about today? We wanted to look at more the Canadian population and what's happening today. In general, across the globe, there's been over 1 million series, which is kind of unbelievable when you think about it. But Canadians, generally speaking, about 50% of them to 60% are aware of what podcasting is. And almost 50% have actually listened to at least one podcast. And then, so who are the most active listeners? Well, there's, it tends to be higher educated, employed, younger people. So, which is kind of interesting. Of course, you know, millennials, I think, are your classic population. But steadily, I think it is increasing among the older age groups as well. Mm-hmm. So briefly, just types of podcasts in general. So this is not for medical podcasts, but we've laid out a few here. I don't think it's completely inclusive, but I think it's the 6 most common types of podcasts you'll come across. And there's some examples for each too. So the most common is probably interviews. And that's really where there's one host and they have someone on and they ask them pre-prepared questions. And so an example would be Alec Baldwin's Here's the Thing, who I'm a big fan. So if you ever want to listen to his podcast, it's actually very, very good. He's very insightful, surprisingly. Conversationalist podcasts are more unprepared and usually just kind of conversations on a given topic. So one example is Smartless, which has 3 actors on it, and one actor will bring on a host and the other 2 do not know who the host is. So most recently they had Kamala Harris on, and it was a good one where it's more, they're not prepared, it's more conversationalist. Educational is where they really, you have a topic that you're being taught about. So huge range of topics from philosophy to history to medicine. But this one, I've just put Stuff You Missed in History Class, which is also a good podcast. Solo cast is more where there's one host, they don't have anyone else on, and they're just talking the entire time. So a good example is Dan Carlin's Hardcore History, where he talks for 4 to 5 hours on a certain historical topic. And then you have kind of your more storytelling, so non-fictional stories, which we mentioned, Serial, more true crime podcasts, and then also fictional. So now there's also a good following of certain fictional stories. One that was recently released is a musical called 36 Questions, because musicians can't really perform live right now. So this came out of the quarantine and COVID. So lots of different types of podcasts, but of course we're going to focus on the medical ones going forward.
And yes, I know we're getting all really excited about podcasts in general, and I'm really loving this chat recommendations, but we do have to talk about medicine today. So with that, we'll divert a little bit into talking about medical education after understanding sort of where podcasts come from. And at some point, you'll see us sort of marry the 2 together, talking about medical education and how we think podcasts can be an effective medium for learning within it. I'll take you guys back a little bit to 2 really key figures in medical education. So Abraham Flexner and William Osler. They are 2 figures in the 19th century who really reformed medical education into what it is more similarly to today. So Flexner is famous for writing a really landmark report about medical education in the US and in Canada. And at the time, there were schools literally everywhere, and he really called to reform them so that they would become associated with universities, because he had this firm belief that medical education had to be married to the basic sciences, that you had to have that foundational education before you could have a career in it. He spearheaded the incorporation of all these medical schools into universities rather than isolated institutions. He raised the standard for admissions and graduation criteria for physicians, and as a result of this, a bunch of medical schools ended up closing. in the United States in particular. And then as a complementary half to Flexner's model, William Osler, as probably everybody knows, he really revolutionized this idea of bedside learning. He was the first person to take medical students out of the lecture hall and to the bedside so that they could learn what patients were like and how to actually care for them. He created the first residency training program for subspecialty training. And he's really the big person who's created this idea of like the clinical clerkship. But as Flexner's model was super popular, it was really important, again, to teach those basic sciences to medical students. And the most effective way that this was delivered early on was by large-style lecture didactic teaching. And over the last couple of decades, I think between all of us in the audience, we have watched medical education change from the early days where it was just speaking. Then we had those slide projectors with the transparent slides where we were writing on them. We had, a lot of excitement when we then had PowerPoint and Prezi where we could animate things for our audiences. And in the last decade or so, medical education has really moved towards smaller group learning, case-based learning to enrich discussion. So rather than just this traditional style of learning, now we see that there are not only didactic lectures, but small group learning, anatomy labs, simulation, and now most recently, this virtual education piece. And why did that happen? So one of the biggest reasons for how medical education has evolved in its teaching has been because we understand better how people learn. So this is a graphic from a website that I really like called The Learning Scientists. It's hosted by a group of cognitive psychologists, and their mission is to understand and then disseminate this idea of evidence-based learning. And because all of us are big fans of evidence-based medicine, I think it's really important to think about learning from an evidence-based perspective as well. It's been shown that that passive learning we get from didactic lectures is no longer the way that invokes the most learning. And so when you think about the ways that we do best learn, there's 6 sort of big categories here. So elaboration, like explaining, describing things, retrieval practice, so having quiz questions as you've personally experienced to test that knowledge that you've acquired, spacing out your studying over time, using different audio-visual aids to code that learning in different ways in your brain, learning sort of different topics in an interleaved practice, and using specific concrete examples to consolidate that information. And so when we take all the ways that we most effectively learn, obviously medical education has evolved so that we can most effectively learn, and not only within the period of time that we're in medical school or residency. Physicians and allied health are all lifelong learners and continue to build their knowledge bases long after they're in independent practice. So knowing how we most effectively learn is also important for once we graduate. But this is all a little bit different now. Medical education is facing a whole different other challenge right now. And COVID-19 is just an example of how medical education continues to evolve and now must rapidly evolve in the face of a pandemic. The model we used for learning even just a couple of years ago is now much harder because we can't meet in person. Most of our learning is virtual. We're unable to see our patients as often from a PPE perspective, from a bedside learning perspective. And sometimes we're being redeployed to different services where it's not necessary, it's more about caring for the patients and serving patients in light of a pandemic rather than necessarily what's the most focused for our learning. And this is just from a learner side. When you think about it in parallel, even without a pandemic, once learners graduate from medical school and residency, learning becomes a whole new challenge because you don't have a formalized curriculum anymore. And especially if you're not at an academic tertiary care center, you have to find a way to be able to learn outside of a built curriculum as an independent practitioner. And for that reason, keeping these sort of 6 basic learning methods in mind, learning has become, like, the trends within learning are completely different than they were a couple decades ago. Now, when we think about our learning, we want it to be mobile. We want it to be accessible from our laptops. We want it to be accessible from our phones. We want it to be social in some way. So group discussion based, and I guess now virtual group discussion based. And I think even as I've grown up, I've seen things become very much on demand. It's not when learning is given to us, it's when we want to seek learning out on our own time and the things that we want to learn. We want it all on demand, just like our Netflix and our Amazon Prime. We want our learning to be modular and adaptive so we can put it together. We want it adaptive in the sense that it can suit asynchronous learning needs, and a blended model, meaning it can sometimes be in person, sometimes it's virtual, and scalable. So the vast majority of medical education resources that are out there right now can go from just one learner to being available to mass audiences. And so when you think about these two people, so the learner that's in the middle of a pandemic and trying to maneuver their medical education, and then even the independent practitioner, pandemic or not, who's trying to keep up their skills in a time where they're not within a formalized curriculum anymore, we raise the argument that we think podcasts are an effective medium for both learners and independent practitioners to stay on top of their medical education.
All right, so we went through the types of podcasts in general. This is creation of categories for types of medical podcasts. And again, it's probably not all inclusive, but the first is probably the most common that you'll see, which is essentially just the episode focuses on a medical topic. This can either be having a host who has an expert, and then they interview them and they go through an approach to a certain general pediatric issue. It can also be learners who've gone out and done the research, and then as they're presenting on the podcast their findings. So Paeds cases is a good example of learners who are medical students, and they choose a very good general pediatric topic, and then they teach their listeners on that topic. The next one is current events in medicine. So I'm sure lots of you have heard of White Coat, Black Art with Brian Goldman, who's an emergency doctor in Toronto. And he tends to do more of current events in medicine in society today from usually a Canadian perspective. For example, his most recent episode focused on a lady with sickle cell and her experience with pain crises, and kind of how she's treated by emergency doctors when she goes for her episodes. So really insightful and good ways of listening to patient stories and doctor stories. The next is a nice one if you yourself have a hard time keeping up with the latest journal articles or studies. So there are podcasts out there that do a nice summary, and they're engaging and easy to follow on the latest research that's coming out of pediatric things. So one here is JAMA Pediatrics has an editor summary podcast where the two editors of JAMA Pediatrics choose their favorite studies from the most recent release of their from JAMA, and then they go through those and they talk about the limitations, but also what they like about the studies. And then the last one is what I've called narrative medicine, and it's really more about listening to patients' stories and listening to other healthcare providers and really learning about their experiences. And we'll talk a bit more about that in a bit. But just to set the mood, we thought we'd play a very short clip of a podcast more from the first category. So it's a host interviewing actually one of our own CHEO doctors, so you can see if you can figure out who it is. And it's from a podcast called EM Cases, which is from North York General Hospital, one of the emerge doctors there who tends to have really great episodes on various medical topics that are relevant to emergency medicine. So here is the clip.
With fever. Dr. Reed, let it rip.
So my best case ever was a 9-year-old previously healthy girl who presented to a family physician's office in the suburban area of Ottawa with a history of having vomiting and diarrhea for a couple of days. She lived at home with her teenage brother and her dad, and the dad had gone off to work that morning and leaving the adolescent brother to look after her. She had fairly significant losses in terms of vomiting and diarrhea. But when he got home from work that afternoon, she was really sick. So she looked very unwell. He was quite worried about her, so bundled her up into the car and took her to the family doctor's office. The family doctor assessed her. He did a full set of vital signs and wrote a note that stated that her heart rate, remember she was 9 years of age, her heart rate was at 140 and her blood pressure was 77 on 40. Her respiratory rate was 36. No oxygen saturation was done, and he wrote a note saying that he was worried that she looked sick, and he sent her by car to the emergency department.
So if you want to know what happens next, it's episode Best Case Ever 27 on EM Cases.
Okay.
Viv, can you show me the slide?
Yes, absolutely.
Okay, yeah. So now we're going to talk about, sorry, we changed the order at the very last minute recently. So we're talking about kind of transitioning now to residence and medical education and podcasts. And we'll start referencing some literature that we found kind of to support the use of podcasts or just to explore the use of podcasts. So there was a survey done in 2016 of Emerge residents that explored their use of podcasts. It had about 350 participants and surprisingly found even 4 years ago that 88% of the respondents used a podcast at least once per month for educational purposes, and 48% use one at least once per week. There's also a review that we found from 2019 that looked at kind of who was using podcasts for education. And so we found this interesting because it showed that there were lots of physicians who were post-training who were using podcasts for medical education, residents and students, of course, as we expected, and then other healthcare kind of providers, including nurse practitioners, physician assistants, pharmacists. And so really anybody who's a healthcare provider is using podcasts for their education. And then just to make it more close to home, over the past couple weeks, we sent around a survey to all the CHEO residents and just asked a simple question, do you use podcasts for your own education? And we found that 65% said yes and 34% said no. The kind of in the literature, there's 4 main reasons that are cited as to why we use podcasts. The first is edutainment. And basically the idea that you're being educated while also being entertained. Often there's a conversational style that the podcasts use, and it allows you to feel like you're kind of getting to know the hosts as they speak to you. There's a low pressure environment. It's often kind of funny, and it has been actually found to create a sense of kind of camaraderie and trust as you feel like you get to know the host, and it can kind of affect your learning positively in that way. The second reason that we use podcasts is it's an effective use of time. So often we can do other things while we're listening to podcasts because it's portable. We can be commuting, either say driving, listening to it on our Bluetooth. We can be walking to work and exercising, anything that you like. You can be learning while you're doing it. The third reason would be staying up to date. So similar to what Heather was saying earlier, it can be challenging to keep up to date with all the new literature that's constantly being kind of published. And so critical analysis in the form of podcasts is nice in that reviewing journals is kind of digested a little bit for you, and the critical analysis is often done. The sources are reputable, and it just allows you to either learn core content or keep up to date with current literature. And then the fourth reason would be to kind of increase our overall knowledge that can impact our practice. It allows you to hear the opinions of and approaches of other physicians, which is kind of important for like reflective and ongoing adult learning. It can allow you to have preparation for questions that you could come across on the wards, expands knowledge base. And in the review that we cite at the bottom from 2017, it was of Emerge residents. 72% now they're in training, and so we can interpret it through that lens, but they said that podcasts did change their practice. And then looking at a bit more detail into the responses that we had from our CHEO survey, the reasons that CHEO residents cited were very similar for why they do use podcasts if they responded that they do. So the commonest responses were that they're convenient, they fit your learning style, they allow you to multitask, and you're an auditory learner.
So when we look at the evidence for podcasts in medical education now. There's a couple of studies. It's obviously a reasonably new medium to medical education. So a lot of the studies are about it as a supplemental learning tool and how it's effective that way. And that's our central thesis, is that it is a great supplemental learning material and not providing evidence necessarily that it's superior to any other teaching method that already exists. This study was published in 2020. It was a group of ophthalmologists that created a podcast, which you can do too. It's not that hard. And they created a weekly podcast that went through review of questions that would be likely on their final examination. And it was about 20 to 25 minutes in duration. It was conversational, it was free. And this podcast really looked at the feasibility and uptake of a podcast specifically for educational purposes. So they looked at feasibility markers, so their time and cost of production, how sustainable it was, so how many people were downloading their podcasts each month, and how much they liked it. So in terms of how many people were following them on Twitter and how many 5-star or high-rated reviews they got. And so surprisingly not that expensive to run a podcast over a long period of time. And they had a good amount of uptake. They had over 100,000 downloads when it first came out. And every month they were still getting upwards of 15,000 subscribers per month. And generally acceptance and reviews were very positive for the podcast itself. And as I said before, obviously a limitation is that it's not showing that it actually improved board exam scores, but it's showing that a lot of people anecdotally endorse that it is positive for their learning and can supplement their practice.
All right, so looking at a few more studies that have looked at podcasts in medical education. So this one came out of McMaster University, and it was with medical students. And it was essentially just sending medical students out with 2 podcasts, one on adult asthma and one on toxicology. And they did a pre-test and then they did a post-test. I think it was about a week later. And it was just looking at whether these podcasts, actually improved their test scores and theoretically their knowledge retention. And what it found is that there was a significant increase in their pre and post-test scores after listening to the podcast. There was some limitations, of course. There was no control group. It was not a huge number of participants. And one of the biggest reasons that people didn't partake or dropped out was because they said they didn't have time or that the podcasts were too long. But still an interesting look at, it does look like podcasts can help with knowledge retention. The next study was among orthopedic learners, and it was kind of fun. So it was a randomized control trial, and essentially they invited these learners and they would randomly assign them to, they were both in like an isolated room, but one group were given a podcast to listen to and one group were given a textbook to read. And then they gave them a pre-test before this and then a post-test to see which way of studying and learning was more effective. And it does seem that the podcast group did better in the post-test, which is interesting. Now, limitations we thought about was that this was kind of unrealistic. Like usually you're not just sitting in a room completely focused on that podcast. So perhaps the retention was a bit higher than usual. But the students did say that they generally liked and enjoyed listening to the podcast more than reading the textbook, which I probably would agree with as well. And then the last study we have is from 2015, and it essentially was, they looked at 3 different groups. So they looked at students who were given podcasts, and then after they listened to a podcast, they had to answer some quiz questions, and then they also attended lectures. The second group just attended lectures, and then the last group didn't do any of those things. And so they looked at, they would have a planned quiz, and then they also had a surprise quiz later on to see their short-term and medium-term knowledge. So the next slide is a bit busy, but the first 2 graphs on the left with the darker bars is comparing the podcast users who also went to the lectures, whereas the gray bars right beside are just the lectures. And you can definitely see that on both tests that they performed better with those things. And then of course, those who did not go to the lectures or study and did the worst. So the message is to do something. But the limitation we found was that because they were doing a podcast and doing a quiz, it's hard to really say, was it the podcast or was it the quiz, being forced to kind of really think about what you'd learned that allowed you to perform higher. So, you know, hard to really say exactly if podcasts made the difference, but again, another study that goes to show that it probably does help with some learning. And then we wanted to talk about this idea of these podcasts that focus more on telling patient stories. So not necessarily learning, didactic learning and learning about medical issues, but learning about patient experiences and also the experiences of other doctors and other healthcare professionals. And it reminded me a lot of something called narrative medicine, which was a field that was started by Rita Sharon. She's an internist at Columbia University, and she created this program and this course, which is essentially reading and learning about patient stories through almost like a literary lens. So thinking about themes and how to better understand patient stories. So there's no good definition for narrative medicine. It's essentially just the meaning you find in other people's stories, specifically in patient stories. And I really like this quote. It was, while a doctor might be knowledgeable about disease, they do not appreciate adequately that illness changes everything for the patient. So thinking along those lines, there are narrative medicine courses out there and programs where the learners learn to read either texts or patient stories through kind of a literary lens. And there's been quite a few studies showing that people who've gone through these courses do have enhanced empathy scores. They actually change how they approach patients, and they tend to be a bit more patient-centered. They tend to be more focused on creating relationships with their patients and understanding their patients. And so even though these are narrative medicine courses and programs and not just listening to a podcast, I think it does show that if you're open to listening to patient stories, then generally you will become more empathetic and you will be learning a great deal about what they're experiencing. The next slide just goes through the 4 divides that Rita Sharon talks about. And they're good themes to keep in mind when you're listening to a patient's story. And they're good questions to ask when you're trying to explore their experience with their illness. So their belief about disease causality. So for those who don't have a medical background, patients will have kind of an interesting understanding of what caused their illness. Relation to mortality. So often here, you know, I've seen this countless times where families think immediately about, they're very fearful of death and dying. Shame, blame, and fear. So often they're sharing very, you know, facts about themselves that are very close to them and that are difficult to share. And then context of illness, so how it impacts their life and their complete life that we don't really see. So we do have a clip from, it's essentially a mother telling her story. And I think it's something that those of us who worked in NICU can really relate to. And unfortunately, this mother, her little boy died at 2 years old, but this is her talking about grief and not necessarily the grief that we kind of expect. So I think it's a good one. So I'll play that now.
That was really kind of working out for him, and we weren't going to the hospital so very much.
Yeah, so he got out of NICU.
Yeah.
And how long was Tommy alive for? He
was 2.5 years old.
2.5 years old.
And I want to say this too, because I really want to talk about grief, but I was going through grief when I was in NICU.
I was going to say, like, and before I guess we get any further, like with that first experience and like going through that, the really like traumatic premature birth and like trying to deal with the fact that you have an 8-month-old at home and the not knowing about the future of how Tommy was going to be. What was your initial experience with grief like, and how did you handle that?
Well, I didn't know it at the time, but really, like, a lot of people don't see, like, basically I was like, the life that I was supposed to have, like, I was supposed to just be a yoga teacher, like have 2 kids, like live happily ever after, you know. And there I was, like, in freaking NICU and surrounded by neurologists and this and that, and I was like, you know, what's going on? And I think a lot of us don't see grief as, like, you know, the grieving the life I was supposed to have. You know, do you guys ever have that? Like, was like to be, no, but it was supposed to be like that. And like, it's not, you know, like if you think of like going through a separation, like in a relationship, or like, but no, like I was supposed to marry this person, or like, you know, it's like the idea of this life, you were the vision of it that you had, you know.
So that was from a podcast called Sick Boy, where these young guys interview patients, usually with chronic illnesses or families, and one of the hosts has cystic fibrosis, so it allows them really to explore their experiences, and it's a great one to listen to as well.
Okay, so we're going to change gears a little bit. We felt that it was all well and good to list all of the rich kind of learning values that podcasts have, but from a practical perspective, we wanted to also kind of bridge the gap as to how they could maybe fit into everyone's busy schedules. So for any of the trainees who are listening, I'm sure everyone else is aware of this, but the Royal College has created guidelines for physicians to show ongoing learning and for maintenance of certification, or MOC, as we are all lifelong learners. Basically, what the Royal College has done is kind of created these guidelines as to how learning activities of various types are kind of transitioned into credits for the value per se of what the learning activity kind of carries. And there's minimum requirements that the Royal College sets out in terms of credits that have to be obtained per year in terms of ongoing continued medical education, which would be 40 credits per year. And then there's 5-year cycles, and in the 5-year cycle, you have to obtain 400 credits. And there's 3 sections of the different types of learning activities, and so 25 credits have to be within each of the sections. And so failure to complete these requirements can lead to default on Royal College membership, which is quite extreme. And so as we kind of work through all the different ways we can obtain your credits, what's great news is that podcasts are one of those ways. So great. So nobody will ever default on their membership for not getting their CME. And then good news for anyone else that we came across as we were kind of preparing this is that because of all the upheaval this year with COVID and everyone's changes to their practice, conferences being canceled, things like that, the Royal College has totally waived the 2020 requirements for any kind of ongoing medical education. And so they've added a year, and so this cycle is actually 6 years rather than 5. And any activities that were kind of completed this year are like as a bonus that will contribute to the credits required in a 6-year cycle rather than 5 years. And the next slide just shows the main port. This is again kind of directed at the trainees, which is just where all of these fully trained physicians enter all the credits that they've obtained over time. Craig Campbell is an example that we found online. And so as we move forward, we'll just go through the different kind of framework that the Royal College has set out for physicians and the different types of learning activities that are included. So the first kind of section that we'll go through is that's broken down. So section 1 activities are group learning. So another kind of piece of good news is that an example of like a section 1 maintenance of certification activity is actually accredited rounds. And that's what we're doing right now. So these grand rounds are accredited, so would be an accredited journal club or conferences. And then you can see on the far side the number of credits for the time. And then if it's a non kind of accredited activity that's also done in a group, it has fewer credits allocated. So good for everybody listening, we're all maintaining our certification. Section 2, learning. This is self-learning. And so this is where fun activities like podcasts come in. So these can be planned learning, scanning, or systems learning. So things like fellowships, formal courses would be planned learning. Scanning would be things like reading journal articles or book chapters, listening to podcasts or watching videos, and then any kind of internet searching. So when you're doing a lit review to answer a consult, that would be all different examples of scanning. And so podcasts actually are 0.5 credits for every podcast you listen to. And then systems learning would be any kind of practice, guideline development, or kind of quality care committees, or those types of activities. And then the third section is assessment. And so this includes basically any kind of self-assessment programs, chart audits that you might do, multi-source feedback, any kind of performance review or practice assessment. So basically the main takeaway from this is that podcasts are a recognized kind of meaningful activity according to the Royal College for learning. So that brings us to the end of our talk. Thank you all for listening. Basically, we wanted to summarize that overall, medical education is changing. Podcasts are an evidence-based kind of meaningful option for medical education that's recognized by the Royal College. And if anyone is interested, maybe we'll think about putting together our own podcast in the future. So you're all welcome to join us. We'll be happy to take any questions.
Okay, great. Thank you all for that great presentation. So interesting. You did a very, really great job of putting together different ideas, bringing in medical education, and making it very relevant for us. So thank you for that. We'll go to the chat to see if there are any questions. You can raise your hand on the participant list. See if there are. Okay, we have Toby. Go ahead, Toby.
So that was so awesome, although small disclosure, I may have a tiny bit of bias, but amazing round. Thank you so much. And really interesting too to see in the chat all the different things that people are reading and thinking about. So my question for you, and you may or may not have come across this in your literature review, was in listening to the sort of description, I wondered about different learning styles in terms of auditory, visual, and then also different learning theories like the Kolb's learning theory, where you're like an accommodator, for example, like an early adopter who's somebody who like wants to jump in with things, which is the predisposing learning style in emergency medicine versus other types of healthcare professionals, and whether you'd come across any evidence about that in terms of the value of a podcast for certain types of users or certain groups of clinicians versus others. So I guess that piece around it seemed like there was a lot of stuff that was coming out of emergency medicine, which maybe makes sense because they are maybe not the ones who want to read the manual about how the VCR works first. They're the ones who want to jump right in and get her done and move on to the next thing. So any either reflections or things from the evidence that you came across?
It's harder virtually to know who's going to answer. I think that's a really interesting insight. And I think across the four of us, what we did come across, and slight bias, Zoe was the one who came up with the big podcast thing because she's a big podcast listener specifically for Emerge, is that we did find that a lot of the anecdotal evidence and the studies were coming out of emergency medicine, I would say, in our reading. And I think it sort of fits that persona idea that you were portraying as well. And then the other big place I think is just like medical school learners specifically. So people who are in the midst of education. And then as we move away from lecture-based learning into different things, it's being explored as a realm within that population of people as well. But I don't know about the learning styles versus if podcasts are good for that. Because I know that the idea that we have learning styles has really shaped what we do. Like, it's like, oh, I'm a visual learner or I'm an auditory learner. But I have this book, which is here. It's by the learning scientists, so the group that I cited before about the science of successful learning. And it does, and I have a friend who's a cognitive psychologist who says that, you know, learning styles isn't really, it's a way to think about it and advance the way we think about learning, but it's not really like the be all and end all. It's really about using all the different methods to learn. that's sort of my 2 cents about that, and my other plug for the Learning Scientist.
I'm going to jump in here just to respond to that. I think that you raised a really important issue as we see the emergence of podcasts, specifically in medical education. I wonder if you guys could address the whole issue of where podcast listening fits into your own learning. Because yes, we've definitely moved away from lectures. That's been a long time coming. There's a real concern, I know in my own area of emergency medicine, we all love podcasts because it fits very well in our lifestyle. We don't want to read the whole manual because the show's on right now. We need to get it right now. You know, there's good reason why it works in emergency medicine, but there's a real risk of getting all your learning from podcasts instead of going back to, you know, doing that, taking responsibility for your learning, making it more active. And you touched on that, Vivian, when you talked about the Learning Scientist model for the different types of education. But could you maybe just respond to that issue? Or the others as well?
Yeah, I can start to maybe answer kind of with the whole idea of like various learning styles like Vivian was just speaking about. So something that we had talked about as we were creating the podcast kind of presentation was that one kind of way that people sometimes have mentioned that they like to use podcasts, and this is something that I like to do, is almost use it as a refresher or as like a kind of a pre-listening before reading about something. This might not always be possible in terms of timing, but an example of that is like, for example, Paeds Cases podcasts. They are quite similar to CPS statements, and that's something that people tend to like about them. They're less narrative than some of the other types of podcasts we've mentioned or spoken about in the podcast presentation today. But something that I have done in the past is if I'm driving, I can listen to basically the CPS statement in audio form. And then later when I read it, it's almost like I've already kind of read it and it's a bit of a review. So that's kind of one way that it can be a bit complementary. Or if you've had a case, for example, at work and you read about something at work, maybe after work you could listen to a podcast on that topic and solidify the learning that you had in a different way, rather than it being 100% of the learning for that particular topic.
That's great.
Yeah, I agree. Like the way I think of podcasts for myself in a lot of ways is it often gives me kind of building blocks or like a skeleton that I hope to fill in later. Like I think because they have to be entertaining often, they can't simply just kind of list out facts that we're going to have to try to memorize. But at least it gives you kind of the interest in a certain topic. And I think it does motivate me to read about it a bit more in depth later. There are some good, Zoe is a big fan of Paeds Wrap, and I am also. It's one that you do have to buy or purchase a subscription to, but it does give a one-page document on when they talk about a certain topic. They then create this summary that's written out, and it does allow people who are visual learners, and I definitely think I'm more of a visual learner than an auditory learner, to then supplement that information. So I completely agree. I think podcasts need to be just an additional way to learn. I don't think you will pass your Royal College exam by exclusively listening to podcasts, though I wish I could try. So yeah, I completely agree. It has to be like just like an extra tool, and often something we do when we couldn't be doing the other types of studying, probably.
Yeah.
Yeah, and I think that segues a little bit nicely into one of the chat questions in terms of reliability and potential downsides of podcasts as a source. And I think it goes with everyone else's argument that it's not the sole source for truth. And the reliability really depends on your judgment call. So when like the ones that are from JAMA reviewing guidelines, or if you're looking to news podcasts like The Daily from the New York Times, if you trust the source that it's coming from, then the podcast is just an extension of that. And when it becomes podcasts that are more individual practitioners who are sharing their insights, or they're sharing like the best case when you listen to from Dr. Reed, I think those ones are the ones you take similarly to the way you take clinical learning from every practitioner you work with as a resident. So as a resident, and I'm on Emerge right now, so I think it's a good example. You work with a different staff every single day, and they all have different approaches to things. And the more approaches you see and the more cases you see being managed helps you decide how you are going to manage your practice in the future. Because even though there are bunches and bunches of guidelines, at the end of the day, I think as we advance through our training, we realize that there is a huge sea of gray where there are 100 different right answers, and watching 100 different people give 100 different right answers can help us become our independent practitioners as well.
Well said. I've often said it would be great if some of you at the end of your learning could come back and say, from hearing all of you, this is what I think is best. Because you are in the great position of seeing lots of different ideas, and ultimately at the end of your training, it's about how you put all that together and where you're going to go with it. We have a few more minutes left. I don't know if there are any other questions. I don't see any other questions in the chat. To see if there's any.
Hello, can you hear me?
Oh, Dr. Batra, go ahead.
Oh, yeah. Well, thank you, because I cannot figure out on this screen how to say anything in here. Yeah, this reminds me of audio digest tapes, which you used to have in there. What you do is take it and stick it in your car, and tape player there, keep on playing. I would think that would be the similar format we had before of the podcast. And now the thing is, at that time we used to have very restricted number of speakers, restricted articles you can listen to. Now I assume that now there will be a better way of scanning it. Now, question is that, are there any disadvantages, or how easy it is to find the articles on podcasts? Thank you. Is it sort of, what do you do in that case? You know, sort of, you have to scan through all those things in there, or you see a screen like computer, say I want to say something about emergency medicine, neonatology, or cardiology. Do I screen it there, then I can hear a few things from there? How that part works out?
Are you guys able to hear the question? I didn't hear it very clearly.
Yeah, the question is there any restriction or limitation to the files you can access by this method of education? So what can you do? What can you accept? Here, I go to the internet there, I put it on Google, I can find anything. All right, here, is there any similar system exists there that say I can go and look into the various articles there?
Dr. Batra, are you talking about like the articles that the podcasts are referencing?
That's right. Yeah, exactly. That's right. Because I'm referring to the one we used to have, the audio digest tapes in there. What you do, you subscribe to them. They give you the tape. You stick in the car. 3 speakers talking, 3 speakers saying it. All right. If you want another topic, go in there. All right. But always there was the difficulty in finding certain articles in the audio digest tapes there. But now the system has improved, and I was thinking, if I want to see some article, how do I go about it? Is there any Google method of finding it, or is there any other way of looking into that?
Yeah, that's a really good question, and I think there is, though Heather or Steph might need to back me up on this, but with all the podcasts you listen to, oftentimes there is an associated reference list or cliff notes about it in the podcast description where you can access the resources that they cite to. I'm sure you have to likely have like a university login or something to see them, but they are like directly correlated to guidelines or articles that can be accessed and are referenced in the notes. And I think you're right that that's super important, because what you're hearing in a podcast is just the overview and the big picture points that you need to take away, and that when you do want to delve into it, that it is accessible, that they reference their sources where you can read that guideline or that article further.
Thank you.
Okay. So while we're waiting for our last call and any other questions, I'm going to put Mariana on the spot and see if she can help us to summarize the suggestions for podcasts that showed up in the chat group. And maybe our presenters can actually review that list and add to their own, because I think it's a great idea to share ideas for podcasts, and perhaps talk about why you like that podcast, why it's helpful to listen to. And maybe that can be an active dynamic list, because sometimes podcasts change over the years, and it would be very helpful to all. So thank you all for those rounds. Really great presentation, and great discussion on medical education. I really like that a lot. Thank you. Bye, everyone. And happy Thanksgiving to all.